For everyone's awareness, this session will be recorded and will be available after the meeting on the MiHIN website. All attendees will be in listen-only mode. So if you do have a question as the presentation goes on, you can submit those in the chat panel, which is located at the bottom right-hand corner of your screen. As we go throughout the presentation today, we will have some instances in which questions will be answered directly via the chat from our presenters. We'll also hold some additional questions toward the end of the presentation and provide answers at that time. We do have some pretty heavy content for today, and so I anticipate there will be a fair amount of questions that come from that. So if for some reason we are unable to get to all of the questions, please continue to submit them in the chat anyway. What we'll do is send a follow-up email with the answers to every question that was not answered during the presentation. For those of you who are newer here, MiHIN is Michigan's initiative to continuously improve healthcare quality, efficiency, and patient safety by promoting secure electronic exchange of health information. MiHIN represents a growing network of public and private organizations working to overcome data sharing barriers, reduce costs, and ultimately advance the health of Michigan's population. We have 5 focus areas here at MiHIN. The first is convening people to figure out functional solutions. We champion statewide use cases to fairly get data flowing and keep it moving securely among all legitimate parties. We operate as a shared services behind the scenes, as the behind the scenes infrastructure. We provide tools to support daily workflows and coordination. And we help with reporting, conformance, and analytics from data lakes and the longitudinal health record. For today's agenda, we'll start off with a presentation from Drew Murray regarding the MiHIN Operations Advisory Committee, otherwise known as MOAC. Next, Shreya Patel will give a discussion on Hipaa privacy rule proposed changes. And then we'll end the presentation today with a few closing announcements for the group. So with that, I'm going to go ahead and introduce Drew Murray to talk about MiHIN Operations Advisory Committee. Drew?
Thanks, Tracy. Appreciate the time and inviting me here. Just for everyone's awareness, and introduce myself. I'm Drew Murray, the Senior Community Engagement Director here at MiHIN. We'll spend 5 or so minutes to discuss the MiHIN Operations Advisory Committee, which is the key way that we in Michigan engage our stakeholders and really make sure we have that stakeholder voice all throughout. What I'll get here into a minute is our use case factory to make sure the work we're doing in terms of that continuous quality improvement is informed and shaped in partnership with our stakeholders. So a little bit of background on MOAC. I will say at the top 2 folks and organizations are invited to MOAC, those that have signed our Qualified Data Sharing Organization Agreement, or a QDSOA. And it's about, right now we have, I would say, 30 to 40 active organizations in this work. So just so you have a sense of scale and how people arrive at the MOAC table. But in terms of organizational context of where MOAC fits in, you see at the top left of your screen, the Michigan Department of Health and Human Services, which is where the origins of MiHIN started about 10 years ago. They have a governor-appointed Health Information Technology Commission that recommends policy to MDHHS and the state legislature that has a relationship to the MiHIN Board of Directors. So there's exchange of information at that board level. Then you see our executive director, Tim Pletcher, listed there, as well as our COO, Marty Woodruff. And so MOAC really sits beneath that, our MiHIN board and executive management, to help, as I said, share that stakeholder voice on the work we're doing in that governance role. So at the bottom of the screen, you see in the past we've had different ad hoc working groups. For many years we had technical operations, privacy, use case. Those topics are still very relevant. What we've done in the past year to year and a half is really update our structure of MOAC to make sure it's more timely and the work groups are really focused on key deliverables that we've heard from stakeholders. And one topic I'll get into is around conformance. So we'll see more information there, but really updating those topics as we need. We can go to the next slide. You see here, as I mentioned, MOAC, you saw dispute resolution, which will continue that issue remediation. As I mentioned, the updates we've had to our MOAC structure to make sure it's the best use of our stakeholders' time, and we're not asking for more of it than we may need. We moved to this task force and meetup structure. So you see on the left side of your screen, task forces are continuing to be ad hoc, but really have clear members driven by those MOAC members, membership, start end dates to what they're seeking to accomplish, and really have focused content there of what we need to do. So I'll discuss here briefly in the next slide around conformance, but that was a key stakeholder topic around statewide conformance that folks were interested in digging more into. So that was our first task force that we formed that has specific deliverables each quarter that we then report up to the quarterly MOAC that we have meeting there at the bottom of the screen. Meetups can be considered more one-off meetings if we have topics or education opportunities that come up that stakeholders need. So not necessarily a series of meetings, but just a pop-up meeting that we may need some different training on, or getting communication or actually receiving information as well. So that's how we've updated the MOAC structure to make sure it's fitting into our stakeholders' time, and we're getting the information we need to help from a statewide health information network perspective. You can go to the next slide. As I mentioned, the use case factory briefly here in the bottom left, starting with this conceptual idea of defining purposes of data exchange, is really where we lean on our MOAC structure to help define what those data flows should be, developing a plan around those, and working into more of the technical planning and piloting here in the next phase. And then really working it through implementation and metrics around to adoption. So we use the MOAC structure most critically in that conceptual phase, but then making sure we carry through items through this entire use case factory process that we have as part of our agendas at each meeting. So just a little bit of background in terms of the methodology in which we engage our stakeholders around data sharing opportunities. Next slide. Just briefly, benefits of that use case factory approach. The two pieces I want to, or maybe three pieces I want to stress here around aligning priorities, given there's a lot of different things we need to accomplish within the state of Michigan's health information data sharing opportunities. So aligning those priorities is key. Being very transparent about where different use cases are at is one thing. We have a slide at each MOAC meeting around the different use cases and what stage they're in, from conceptual to planning and development, implementation, or that critical adoption piece. So being transparent about where that fits in terms of other use cases that we as a state are pursuing, and then making sure they are actually measurable. We know how much data is flowing through those use cases. So MOAC structure really helps inform priorities, being transparent, and also measurable to help create that engagement with our stakeholders. Next slide. One of my last slides here is just an example of the type of content we cover in MOAC, and specifically these task forces. Some of you on the line here may be engaged in this task force already around conformance, but to date, over the past year, they've looked at common keys, medication reconciliation, those CCDA messages, as well as immunizations and ambulatory endpoints. So just different elements around conformance that we want to make sure all the different state organizations at the table that assign that Qualified Data Sharing Organization Agreement, or QDSOA, can help inform statewide conformance. We initially thought we could keep that group small to have some focused feedback to get back to the quarterly meeting. But as you see, we failed in that work to keep it small given how much interest there was in the topic. But we are thankful to accommodate that increased interest. As you see, a total of, it looks like about 18 organizations across health plans, health systems, physician organizations, and we have the Michigan Association of Health Plans actually at the table, as well as Blue Cross Blue Shield of Michigan and others. So really setting that big table to help with, specifically on this topic, statewide conformance that was very top of mind for many folks that we continue to work on. So that's just an example of the type of table we set for our stakeholders to come to help work through these types of issues, and then reporting progress up to our quarterly MOAC members every 3 months. The other major topic that's been recurring for our MOAC members has been, as I mentioned, MGHHS is critical to the state's work. The HIT Commission is sponsoring this statewide roadmap that we are updating as a state that's been in progress, or we've had the last plan about 10 years ago. So working with the consultant Cedar Bridge and State of Michigan partners, Sarah Esty, Trevor Youngquist, and others, they are leading the effort to update that roadmap, and we're making sure stakeholders are at the table helping stay aware of how that work is progressing, given Sarah and Trevor have done a great job having a lot of different work groups and forums for stakeholders to engage, but we just want to make sure MOAC is offering its assistance there to help with that statewide roadmap that the state of Michigan is putting together. We also have reported out progress on another element of this roadmap is the social terms of health. So we've had workshops and different onboardings take place as a result of the feedback we received from MOAC stakeholders and others. So that's been another key topic within our MOAC agenda. So this slide just gives you a little bit of flavor of what we cover within our MOAC quarterly meetings. As I mentioned, those task forces that happen more regularly than quarterly, but as needed based on stakeholder need, and then meetups that are more one-off meetings as needed. And I believe the next slide is my last. You go there, Tracy. You'll see my email if you have any questions about MOAC, since I just want to spend briefly just educating each of you on MOAC structure if you weren't already familiar with it. Happy to respond to questions in the chat as you have them, but please use this information as your reference and reach out to me at my email there if you have any questions. Thanks, Tracy, again for allowing me some time to talk about the Michigan Operations Advisory Committee. And I believe we're moving next to Shreya to talk about privacy rule changes.
Yeah, thanks, Drew. And just as a reminder to the group, if you have any questions for Drew or any that pop up along the way, remember you can submit those questions in the chat box, and we will address those either via chat or toward the end of the presentation or email follow-up. Okay, next up is Shreya Patel to discuss Hipaa privacy rule proposed changes. Shreya?
Thanks, Tracy. So hi, everyone. As was mentioned, this is Shreya Patel. I am the Chief Policy and Privacy Officer at MiHIN, and today I'm going to be discussing proposed changes to the Hipaa privacy rule. These were released back in December, and right now they're open for a public comment period until next month. Next slide. So when reviewing changes to the rule, it became clear that this was the Department of Health and Human Services' attempt to address many of the provider and patient concerns that had been voiced over the past 2 decades when it came to Hipaa. So this rule addressed areas such as care coordination and individual case management. It encouraged sharing between healthcare providers and non-health services that impact a patient's health. So on that one, think of like social services and social determinants of health. And then third, it reduced many burdens that were placed on providers. So when you think about that one, think about some of those administrative burdens that were in place. Next slide. This proposed rule change is going to specifically apply to HIPAA-covered entities for the most part. But it is worth noting that the way that HHS has worked in the past is it has followed this pattern of imposing requirements on covered entities first and then expanding on to business associates once they see how that's working. So that certainly may be what's going on here, but for now the focus is going to be on those entities that are directly interacting with patients. So think more of your providers and payers and less of the like accountants, the lawyers, and the administrative entities that just support those covered entities. Next slide. When it comes to what is going to change with the proposed rule, much of the proposed rule is actually meant to expand a patient's access to their own health care. So this is going to build on the interoperability rules that were released last year and give patients greater autonomy to do things like take notes and take photos of their PHI in person, find information on how to actually request their PHI in a very easy way. It's going to put some time limits for covered entities to respond. It's going to require covered entities to accept requests to route information to a third party, so it doesn't just need to go to the patient itself. And then also it's going to require covered entities to accept oral requests that are clear, conspicuous, and specific. So again, this is just really building on that concept of patients having access to their own healthcare and really taking control of their own healthcare as well. Next slide. So this is a little bit of a longer slide, and I know there's a lot of text on this one, so just bear with me. But in addition to the last one, it's also going to address a requirement that has been long debated in the healthcare space, and that's identity verification. So before, healthcare covered entities were able to kind of impose these various identity verification burdens on patients and their family members when those individuals requested their own healthcare information or healthcare information on behalf of another. And the reason that they were allowed to do that was to protect a patient's information. However, with this rule change, HHS has since relaxed their stance just to address the fact that individuals and their family members really weren't getting the information that they needed on their own healthcare at the point in which they needed it. So now with these new changes, it would say that covered entities would not be able to require signatures to be notarized when putting in a request for information. They can not only require that requests for their own healthcare information be in person, and they cannot allow that requests only be in person as opposed to like on the phone or something like that. And kind of to piggyback on this topic of easing the burden on patients, HHS has also proposed these parameters for fees that can be charged for requesting your own PHI. And that's largely going to be dependent on the format in which you request it. So for example, if you are getting your records mailed to you, if that's the request that you put in, you might have to pay postage or, for the effort of actually putting together that document to get mailed out to you, but you're not going to have any unnecessary fees along the way. Now, before we move on to the next slide, I will note that on the second bullet here, there was a requirement and a distinction in this rule change that covered entities and plans can submit individual access requests to one another to receive electronic copies of PHI through an EHR. So HHS called this out as distinctly different than exchange through a health information exchange or a health information network, kind of like MiHIN, just because these entities, like ours, typically don't compile patient records in the same manner. But it's worth noting that they did include that requirement, and it's very likely that that could kind of bleed over into the health information exchange over the next decade or the years to come. Next slide. So this rule also proposed 3 new definitions that were not included prior, and the one that would likely be the most interesting here is probably going to be this idea of a personal health application. And that's going to be of more importance as we see covered entities and health plans in particular kind of gearing up to meet the CMS patient access mandate from last year, which basically said that patients do have a right to query information about themselves through third-party applications. So that one might be worth taking another look at. Next slide. So this rule in general relaxed the interpretation on minimum necessary, and by that I mean the requirement that entities only share the information necessary for care coordination with the individuals necessary. And while the general principle is still going to be true, they basically released guidance that in emergency situations, it may not be as stringent as entities have interpreted it to be in the past, particularly when it comes to coordinating care for individual level care. So not necessarily thinking about population health care, but actually thinking about coordinating one individual's care as they move throughout the system. Next slide. Social services and social determinants of health also had a sizable prominence in the rule change, and the privacy rule explicitly now allows the sharing of health information with home and community-based services, which is really a big win for patient coordination. We've seen social determinants kind of emphasized pretty frequently over the last 2 years, and there were still a lot of outstanding questions from entities that said, which organizations are we actually able to share health information about, and do we need patient consent in order to share with some of those entities that might not be typically considered covered entities. So this kind of gives a little more explicit guidance to address those questions that have been existing. Next slide. The standard for provider discretion was actually reduced from requiring providers to use professional judgment, which is a higher standard of care, to requiring them to operate in good faith, which is a lower standard of care during opioid or substance use disorder emergencies at large. So this is, again, going to be a huge win for helping patients receive the care that they need during emergencies, and it really complements and strengthens the 42 CFR Part 2 guidance that has been released over the past 2 years. So this is going to be for those instances where someone is in the emergency for a substance use disorder, opioid incident, and providers have to make decisions on if they should share that patient's healthcare information and with whom. It's just going to give them a little more leeway and really increase that care coordination to just prevent any of outcomes. Next slide. Staying on the topic of substance use disorder, the privacy rule would now allow entities to share information with personal representatives. And here we're going to see the identity verification piece come back up, because entities must trust representations that individuals are who they say they are. So providers can actually use a certain level of discretion in this. For example, if they've seen or met, let's say, a family member before, they might feel more comfortable to share information with that individual than, let's say, some stranger that claims that they have a relationship with the patient. But again, this is just giving the provider a little more leeway and room to coordinate effectively during treatment, and kind of removing some of those barriers that were really meant to protect patients, but that may have just been interpreted a little bit too stringently. Next slide. Now, an administrative burden that was eliminated was the requirement to receive written acknowledgement from a patient that they have received a notice of privacy practice from the covered entity. So this has been removed, and instead HHS has actually given a suggestion of what information should be given to patients. So they have emphasized things like tell patients how to access their own healthcare, how to request access, tell them how to file a Hipaa complaint, and just some of those more practical things that patients may want to know aside from the notice of privacy practices. This is actually something that will likely influence most of the Michigan stakeholders that we have with MiHIN and maybe other entities that have business associates, because usually in your notice of privacy practices, you're laying out how an individual's information is being used from your organization. However, it's not to say that you're immediately going to take all of that information away from the patient. What's likely going to happen is you're just going to give it to them in a different format through something maybe like a privacy policy on a website, maybe giving them, like HHS suggested, more easily digestible, one-pagers or fact sheets on exactly how their information is being used and things like that. So it's just taking out the formality of the notice of privacy practices, not necessarily taking away the information that would go to the patient. Next slide. So this proposed rule also increased coordination to the telecommunications relay services, which helps to coordinate care to those who are deaf, hard of hearing, or blind. And this is really important because TRS was not a covered entity nor a business associate. So in the past, there has been a lot of instances where they were refused access and they couldn't really help to coordinate that care or coordinate that communication. So this is going to be a really big step to increasing coordinated care to these specific populations. Next slide. In the same vein, they proposed coordination with the U.S. Public Health Service and the National Oceanic and Atmospheric Administration to coordinate care for individuals in the armed forces. So again, this is just an area where they had received feedback and noticed that there were just some gaps in coordinated care for these groups or these populations. And so they're kind of resolving some of that by including this within the rule. Next slide. Now, we have read through this entire rule and created this summary so that all of you wouldn't have to, but it's worth noting that there is some other content in the proposed rule that you may be interested in. And for that reason, I've listed some of those items on this slide if anyone would like to go back and reference them later on. I think what will probably be of the greatest interest to this group might be a little bit of that historical background on Hipaa and how HHS has been working on their regulatory sprint to coordinated care over the last 2 years. And this change to the privacy rule has always been something that they've factored in and been something that they were leading up to with the past 3 initiatives as a part of that regulatory sprint to coordinated care. Next slide. So that kind of wraps up my presentation on proposed changes to the HIPAA privacy rule. If anyone has any questions for me, feel free to use the chat function, and also feel free to email me if you have any other questions or follow-up that you have on this area. Always happy to help out or just even have a discussion on what our thoughts are. In addition to this, we will likely submit comments and feedback to HHS. So if there is anything that is on your mind or something that you think is an important area for us to highlight, I'd also be really interested in hearing that feedback as well.
Thanks so much, Shreya, for excellent information that you've provided there. We do have a couple of minutes before we go on to closing announcements for some questions. So Brian, I want to check in with you to see how things are going in chat, if questions are being answered there, or if we have any to call out right now.
Sure, thanks. Thanks, Tracy. There was a couple of questions for Drew that he addressed through the chat related to who the members of the MOAC are. And so those things have been listed in the chat for those who would like to see them. I also included the link to the piece that ran in the interface yesterday, which also links to additional information about MOAC on the MiHIN website. And then Shreya, one question did just come across in response to your comments. And that question is from Julie Lowry, and she's asking if a patient asks MiHIN what information of theirs is shared, is MiHIN's response to go back to the source system?
Yeah, thanks so much for that question, Julie. And sorry to call you out as opposed to responding in the chat, but I can kind of speak to it just verbally. So it really depends on what piece of information we're talking about. Usually the response would be to go back to the source. And the reason for that is because MiHIN typically doesn't open the messages or really digest any of that content. We're merely routing it from point A to point B. So you would really have to go to the sender of that information to see what was encompassed in that message. The one kind of caveat to that is our virtual integrated patient record, which is called Viper. When we had our affiliation with GLHC, we kind of acquired this really amazing tool for patient coordination, and that actually allows us to compile all the information on a patient as they move from entity to entity throughout the state of Michigan. That would be an area where MiHIN would be able to actually respond back to what information of theirs is being shared. Again, it would only be for the information that the patient has in their virtual integrated patient record, but the way that they would go about receiving that information from us would be to submit an accounting of disclosures. And through our legal agreements with the covered entities that we're connected to, we have a legal obligation to respond to patients when they put in those requests.
Okay, another question. Do we know, or do we know what the date is for when those privacy changes need to be implemented, Shreya? And is it possible for us to provide a link for that reference?
Yes, I am not remembering off the top of my head the exact dates. It is listed in the proposed rule, and I'd be happy to share the link to the HHS website that has that material and follow up afterwards on that.
Great, thank you. Next question here for, again, Shreya, is do you know how the proposed changes will affect us when Michigan law supersedes so much of Hipaa because it's more restrictive?
Yeah, that's a great question. And we can kind of look to what a few other states have done in respect to this as well. Like, for example, I know that Texas also has a few privacy laws themselves that are much more stringent than Hipaa. And it really comes down to how the entities in the state are interpreting the laws. And what I have kind of witnessed and what I have found is that usually what will happen is it will be the most stringent law will be the one that controls, just because you know, a lot of our legal agreements, it says that we need to follow all applicable laws and standards. So while that would include, you know, federal laws like Hipaa, would also include state laws in Michigan that might face a more stringent requirement. What I would also say to that, though, is when the Michigan legislature sees changes like this come down and out of the federal government, it might ignite a new conversation on a statewide level of, should we re-examine what our own laws in Michigan say? And maybe that's something that, you know, we could reach out to the Health Policy Committee in the legislature to see what their feedback might be on that. But I think that what has kind of been happening over the past 5 years, and I could see happening over the next 5 years, is there being this conversation of, did the laws that we wrote, you know, 20, 30 years ago really make sense now that we're moving in the space of electronic health information exchange? And if they don't make sense, how can we make sure that they are rewritten in a way that can really accommodate this new technology landscape and this new kind of healthcare climate that we're living in?
That was a comprehensive answer, Shreya. You actually covered the follow-up which was about whether or not Michigan is known for adjusting their laws to be in compliance with the federal. The last question that I have is just asking if the slides will be available to share. And I can say, I'll answer that one and tell you that yes, in fact, that they will be. And I believe that you should be getting a follow-up email to the download, and the slide deck will be attached in that email. So everybody who is registered or attended will have access to these slides. That is the extent of the questions that I've got thus far. If there are more, we do have a couple of additional minutes. I'd be happy to address those things for you now. Otherwise, please feel free to reach out to Drew or Shreya directly, and they will be happy to provide any additional information as well. Tracy, back to you.
Thanks so much, Brian, Shreya, and Drew for helping answer those questions. We will wrap up here with a couple of announcements. And again, if there are any other questions, we'll probably have just a couple of minutes left over. So please continue to submit those questions in the chat box if you like. So the first announcement is regarding a Phi Consent Tool that's been developed to help providers navigate regulations around the release and exchange of Phi. A video series has been posted to the MDHHS website to help Michigan stakeholders understand how to navigate this tool. For more information, you can visit their website, or you can take a look at this month's edition of the interface. Additionally, I wanted to let everyone know that MiHIN is convening an imaging workshop series beginning January 27th from 2:30 until 5 p.m. based on interest received initially from Michigan hospitals. We at MiHIN do have an existing use case in this space that can be used as a starting point for the discussion to further understand current stakeholder needs in this area. Please save this day if you're interested in attending and contact myself, Tracy Webb. You've got my email address there. If you have any questions or would like to receive more information outside of this forum about the workshop series, we'll be sending out the official invitation on that shortly. Also wanted to just take a couple of minutes to remind everyone the who's who of the account executive team. And so we've got 3 senior regional account executives. Chris Ford handles the western or orange portion there on your screen of the state. Brian Bullock covers the central area or that green section. And Greg Kavanaugh covering the east side purple section there. Your contact information is listed below, and you can consider them your primary point of contact if you have any questions or inquiries around our service offerings. I also wanted to take just a minute to highlight our corporate account executives, starting with Marty Woodruff, Chief Operating Officer serving the state of Michigan. Drew Murray, who we heard from earlier in the presentation today, Senior Community Engagement Director servicing state of Michigan, Michigan Medicine, and Trinity. Bo Bernanke, Emerging Solutions Manager serving Blue Cross Blue Shield. Megan Gibbs, Corporate Account Executive serving Ascension and McLaren. And finally, Matt Stromer, Product Sales Manager serving Medicaid health plans. So again, contact information is listed there. I'll give everyone just a moment to jot those email addresses and names down if need be. I want to check in real quick, Brian, to see if any last minute questions have come up.
No additional questions, although Shreya did add a comment to the chat, so I want to encourage everybody to check that out, that the proposed rule was released on December 13th. HHS has stated 60 days to provide comments, 180 days for the compliance period, and 240 days to the enforcement period.
Okay. Thank you, Brian and Shreya. All right, well, that wraps up this edition of the download for this month. You can join us for the next edition that will be scheduled for February 2nd. If anyone has any questions, again, please always feel free to reach out to me. We're here to help. Appreciate everyone's time this morning. Stay warm, and we'll see you next time.